Well, ladies and gentlemen, I'd like to welcome you all back to the Merge Medical Podcast. I'm your host, Dr. Jeff Brown. I'm joined by my co-host, Dr. Jeff Cole, and Dr. Brittany Busse. She is the co-founder of ViTel Health, which is a champion for independent physician practices, equitable care, promoting lifestyle and food as medicine. Did I pronounce your name right, Brittany?
Yep, that's right.
All right, welcome. I don't know much about ViTel, but we were chatting offline. It sounds like something that we all should be interested in, especially after the article we just posted about 40% of physicians are contemplating leaving the profession in the next 2 years. Kind of scary, right?
Yeah. I mean, if you even look back at during COVID, I think, they estimated we lost about 17 to 25% of the practicing physicians directly from their practices. And those weren't just physicians who were retiring out. Like those were young, early practice physicians who should have had long careers in the medical system. And for the most part, we don't know where a lot of them went. Some of them did start direct care practices. Some of them are still looking around to see what's out there as far as consulting agreements. A lot of them aren't sure if they even still want to practice medicine anymore, if it's worth it, if they can afford to compete in a corporately owned market. So we initially founded ViTel Health back in 2020 and incorporated in 2021 as a platform as a service model. So beyond just offering software, we wanted to offer physicians a place where they could find everything they needed to launch an independent practice of their own and to thrive in that practice. So we would source everything from discounts on contracting and credentialing to malpractice insurance to the legal aspect that the physicians needed in order to spin up a corporation. We had contacts in bookkeeping, accounting, and overall, we were just trying to focus on helping physicians start the lowest cost practice that they could, which was a digital health practice, a direct to consumer digital health practice. So why should patients be forced to go to a Teladoc or an Amwell and get a 10-minute appointment with somebody they've never met before when they can have a direct primary care physician or a direct specialist relationship where they can go to that person no matter what it is that they need. And they know that when they text that number, when they sign up for the video visit, when they have a telephone call, they know exactly who they're talking to. They're talking to Dr. Busse, they're talking to Dr. Brown. They know what to expect and you know who they are too. So those types of conversations go a lot easier than trying to explain to some person you haven't met before what your entire medical background is. You're prone to leave things out. And then, 2 weeks later, they told you had a virus. They said, come back in 2 weeks if you're not better. So you come back 2 weeks later, you get a different doctor. And that doctor's like, okay, explain the whole thing to me again. Like, well, I want to talk to the last doctor because they told me in 2 weeks I could have antibiotics if I wasn't better, and that's not the type of experience that people want from the medical system, but it's the type of experience that they're having, whether they go, like I said, to Teladoc, or even if they go to their primary physician's office in a hospital system. My son's been seen by no less than 4 different doctors, and he's only 2 years old. And every time he's been sick, we can never get an appointment with his pediatrician. We have to see whatever pediatrician or resident pediatrician or nurse practitioner is available to see us. Larger hospital systems and even like One Medicals and all of these other places, they're replacing us with mid-levels because they're cheaper. And they think they can do the same job as we can do. And the patients are not happy usually with that, but there's nothing they can do. They're kind of trapped in the system. So I've talked to a lot of physicians who were let go by large medical systems and replaced with mid-levels. Like, well, what do I do next? And I'm like, well, just open your own practice. And like all those patients who are stuck seeing the mid-level at the hospital, like they want their doctor back. So you just start your own practice and, let the patients know where you are. And a lot of them are going to come back. So it was really an independent practice platform that wasn't just about the EHR. It was also about the services that we can collect and utilize together to form an independent practicing medical group.
Well, it sounds like that's a lot of moving parts. Like, I don't see how you put that all together. Walk us back, like say I'm a pain physician and I've got a pain practice. How would I come to ViTel and say, hey, I want to set up my own practice. Walk me through the process if you can.
Yeah, so our product has definitely evolved over the past 2 years because, like you said, there were a lot of moving parts. And it was initially, we wanted to create like a bespoke medical practice experience for them. It ended up requiring a lot more upfront costs on our part. It wasn't a super viable model. So if you had come to us at that time and we were starting up a practice for you, we would have connected you to our credentialing specialist, gotten everything up and running from that standpoint. If you needed to contract to insurance companies, they could run you through that process. From a legal aspect, like I say, you haven't started anything at all. Like you don't even know, if you need an LLC or a
Right.
corporation or, how you want to structure your practice. Our legal experts would walk you through that aspect of it. Even just simply down to, I just need technology. So we have an EHR platform that's proprietary to ViTel Health. It was initially built out for specialty practices in workers' comp and occupational health, but it's really highly adaptable to any kind of medical practice that you're starting. So we have like dermatologists on the platform, neurologists, pain management specialists, OBGYNs who do like hormone replacement therapy practices, obesity medicine practices, in addition to internal medicine and family medicine practices. So a lot all over the place. The system's very flexible. So unlike legacy systems like Epic, we particularly built our system to be modular so that you could easily swap things in and out, turn things on and off. So depending on the view that the physician wants to take and the workflow that the physician has, we can kind of swap things out to make it more customizable very easily, where most of these legacy systems or even some of the cheaper systems like Practice Fusion and Charm, like it's just, you buy it, it's out of the box, you make it work for you, they don't make it work for you. And we took a very opposite approach to that, as far as, we know the system's not perfect. It was built for one specialty. It works really well. Anyone can run a practice on it for an MVP, but you want things that work more particular to your workflows and the way that you've always done things. We take that very seriously, that this is a tool for physicians, made by physicians to meet their needs. It was never intended to be something that is just used only one way.
So if I'm a physician sitting at home listening to this, I've watched the last few years practices get forced to be bought by hospitals or forced to be bought by private equity because they can't afford the EMR because it costs gazillions of dollars. So you've got, Dr. Brown that's got his pain practice, or Dr. Cole, an internist. He's had to join groups because he can't afford it. So my first thought in hearing this is, how did you make it so affordable and that anybody can pick this up and it be something they can put into their practice, their independent practice, by the way?
Yeah. So, we were very fortunate that we had a system that we had spent many years building for another use case in telehealth. And like I said, it was built as an occupational health tool. It was utilized by many physicians treating patients at large self-insured companies, including myself. When that company rolled up, we kept the technology. So it's been in use since 2013. So it's a 10-year plus shelf life of usefulness at this point, and it's constantly adapting. So there wasn't a lot for us as far as to make up the cost of the development of the technology, but the ongoing development and support is really important. And we support that by having other platforms and other services that help kind of subsidize, I guess you would say, the EHR proper. So the EHR itself would only cost a practice $95 a month.
Oh, that's really cheap.
Yeah, but we have an accessory platform for remote patient monitoring and chronic care management. That's actually a completely vertically integrated system that I run so that a practice can utilize it without any additional administrative cost, without any additional people costs, so no HR costs. We employ all of those individuals, and we're able to create an additional revenue stream for the physician practice that also creates a significant revenue stream for ViTel Health so that we can keep all of our technology running on AWS platform.
That's fantastic.
That's great. What have been the early results for remote patient monitoring, and what are the feedbacks? Is it, I mean, I get worried sometimes when fantastic solutions come along, but they're seen as a money grab and people use it improperly and then it gets taken away. Where do you think we stand there?
Yeah, I think it was really tricky when we started probably about 18 months ago with our first client. The technology was simple for us. Like my partner is CTO and CEO, and he has a technology and medical technology background, and a real passion for helping individuals with chronic disease. Both of his brothers died from preventable conditions related to diabetes and heart disease. And he was really passionate about bringing the remote monitoring technology. And, as you mentioned in the intro, like I'm really passionate about lifestyle medicine. Myself, I've never liked prescribing pills. I actually went into surgery initially as a resident because I said, like, I'm not going to be a prescriber for my entire life. Like, I just could not see myself as internal medicine or family medicine. It wasn't in alignment with how I live my life. So I live my life, pretty drug-free, a lot of natural things, eating clean, exercising. I'm a yoga instructor. So I said, how do we blend my way of being in the world and my own medical leaning with what we're doing for physicians' offices? Because physicians just don't have the luxury in most cases of knowing a lot about nutrition or how to deprescribe medications or how to manage chronic diseases, especially talking to Dr. Cole and other surgeons with having a surgical background. It's that I don't know how your experience was as a resident, but I know my orthopedic colleagues would often call the hospitalist as soon as their patient was admitted, just in case something happened to happen and they needed a sliding scale or they needed some blood pressure medicine. They were just
anything.
Like, don't call me for that.
Yeah.
And so our idea is to always provide that line of support, whether it's to a primary care physician's office with our panel of health coaches and nurses who actually guide patients through, their nutrition, their exercise, through stress management, through removing any of like addictive substances from their lives. Just really helping them from those like 7 to 8 key areas that lifestyle medicine focuses on to get a holistic picture. And we like to hire certified health coaches because they have that background that we in the medical profession often lack when it comes to how to have a motivational interview with a patient, like how not just to listen, but then also to help the patient with the help of like cognitive behavioral therapy techniques and other things to actually change their minds about their current health journey and their current lifestyle and their current relationship to their chronic diseases. So by utilizing our health coaches, they create these amazing relationships with patients. Like I said before, like this is relational, this is medicine. We cannot expect that these one-off appointments are going to lead to any significant change for anybody. So our coaches take a very, targeted one-on-one approach with patients. They carry a, reasonable panel so that they can meet with patients at least twice per month and continue to work with them on their goals. And both the patients and the doctors absolutely love it. So we've had patients who are, being deprescribed hypertensive medications that they've been on for years that are, finding ways to better manage their blood sugar. They're losing weight. They're happier. We had a patient who's in his late 70s tell us he feels better than he did in his 50s. But above all, the patients are actually feeling really seen for the first time by the medical establishment. So whether that's just a single concierge physician or a larger group practice, the patients finally feel a connection to those practices. So they're less likely to just up and leave and go to the practice down the street because they feel like, oh, for once the doctor sees me and the doctor partnered me with this other person. I said the revenue from that, like you said, it was kind of seen as a money grab. We have a lot of bad actors, frankly, in this system, and they are putting a lot of risk on the physicians whose NPIs they are using to bill Medicare for these services. So from our standpoint, it was really important to have a fully integrated program that meets all of the compliance, that meets all of the documentation, that ensures that the physician ordering these things and billing for these things is at, like, I don't know if they're ever zero risk, but it's definitely as small as we could reasonably expect to get it in terms of triggering an audit, of having the DOJ look into what you're doing in your practice. And so in order to do all of that, we end up splitting the revenue 60-40 with the practice, where we take 60% to cover all of our costs associated with the technology and the employment of the health coaches and tax and all of that stuff and compliance. And then giving that money back to the physician practice as essentially passive revenue, because they don't have to do any of the documentation. They don't have to do any of the billing. They just need to send us the patients and follow up on any alerts that we send them. So it works great for primary care. In terms of our surgical colleagues, we definitely see this as a program where we could pair a primary care physician out in the workplace, maybe one who had left practice previously and is looking for patients to care for, with that, surgical practice, in order to optimize patients preoperatively and also care for them through the postoperative period, using the remote monitoring and working together with the team of health coaches. So it offers an opportunity for the surgeons to practice more safely in the ASCs, and to know that their patient vital signs are being monitored postoperatively, as well as those preoperative things that you need to do. So what's the most important way most surgeons avoid postoperative complications is through good preoperative planning. But if you're just looking at a diabetic patient's hemoglobin A1C, you may not be getting a good picture of where they're at right now, right? So let's just take a knee replacement patient who's been in pain. Their inflammatory markers are likely elevated. They may be eating poorly. They're likely not exercising as well as they were. So even if their hemoglobin A1C was normal 6 months ago or 9 months ago, that doesn't mean that their blood sugar is normal now. So we want to take a look at what is that blood sugar now in the immediate preoperative period, and can we get that under better control immediately preoperatively and postoperatively, after we do damage essentially to the patient by cutting the skin, cutting the bone, hammering the new hardware in there, that causes blood sugar spikes. So we want to make sure that those things are monitored, that they're cared for in the immediate postoperative period, so that you don't have infections and so that the patients recover better. So there's a lot of ways that we can utilize remote monitoring to boost the throughput and also the revenue of many different types of practices.
I think humans are social species, right? And even the most shy person wants that interaction. They want the consistency, and I think what you're providing is fantastic. And it just makes me think of the example, and I don't remember the name of the company right now, but basically the AI doctor in a square silver cube. It's like
Forward.
what Silicon Valley thinks of us, and the importance of that direct human interaction. Because I just think that patients they need that. I think they thrive on that interaction and what you're providing through those health coaches. I think that's a really fantastic twist to the treatment model. And I guess if there's a question here, when I looked at your EHR in particular, I'm looking at it going, I probably could do a lot more virtual work, because right now I do zero. But at the same time, there are a lot of patients in my practice that I have to see. I can't inject them any other way. And I think, primary care physicians, when it comes to something, annual rectal exam or whatever, you just can't do that through the computer. So your EHR would support a in-person practice as well. You just line the patients up in the queue and see in the same way. Is that true?
Yeah, we have a whole scheduling area, so you could potentially, the way I see it mostly is that physicians would want to kind of split up their day, right? And or their week, more likely than splitting up their day. I think the way that hospital systems tend to see it as just as like, oh, you're just a bunch of time blocks. Like, I'm going to stick a virtual visit here, and then you're going to see 2 people in person, then you're going to do 3 virtual visits, and like the physicians kind of scattered at that point. Like, it's really hard to switch from these in-person appointments to the virtual appointments, and then you might have a technology issue that makes the appointment run late, and now you're suddenly behind on your in-person visits. So it can get pretty complex from that standpoint. There's a lot of research about attention switching, and although you're technically doing the same task, which is evaluating patients, virtual evaluations require a different set of skills. So I started doing telehealth in 2016. I actually would go around and give talks at a lot of major medical conventions about what we termed like basically webside manner instead of bedside manner, because the way that you treat patients, exactly like you said, is very different. When you're seeing them in person, there's often a physical thing that needs to be performed or done to them, whether that's like a treatment in person or a diagnostic in person. For the most part, what you have to be able to do in a virtual visit is maintain open lines of communication, just like we're doing now. Like, you have to have turn taking, you have to allow the patient to finish talking without interrupting them. You have to reflect back to the patient to try and get more information out of them, because 80% of the diagnostic capability that you're going to be able to utilize from that visit is going to come from a good history. Like, you're not going to do very much, if any, physical examination of the patient, unless, like I said, in the terms of occupational health, workers' comp cases, I had a lot of musculoskeletal injuries. So I might have them, show me their wrist and like do some things. Or if I was going to test them for carpal tunnel, I would have them, like mock what I was doing and ask them what they were experiencing. So I think it's a lot of the same thing that we do in person, but there are very subtle differences to that take different parts of your brain. So it would still be a different task, in my opinion. So I would see physicians having, just like you probably have like your clinic day versus your OR day. You're not trying to like, I'm going to go do this like hand surgery, and then I'm going to pop back to clinic and I'm going to see 4 follow-ups, and I'm going to pop back into the OR. Like, it would be a lot of back and forth for you. So like, the surgeons have operating days versus in clinic days. It's important for physicians who have a hybrid practice of in-person patients and digital patients to work out what blend of time they want to spend in person versus what time they want to spend digitally. So we've looked a lot at that as far as like, can that be a resource sharing opportunity, right? Like, if you're the surgeon and you're going to use the ASC these days, then you might have other people using it on other days. Obviously, it's not just sitting empty on the days that you're not there. The same thing with clinic space. So if I'm a doctor and I've paid, $1,000 a month to rent this small office space just to see my patients in person, are there potentially 2 other doctors in my locality who might want to also share that space with me, and we can operate virtually on the days we want to be virtual, and then we just share the clinic space as well. So there's a lot of ways that we've looked at reducing the cost of these like physical and tangible items.
I had a question about I think you called them, are they lifestyle coaches or healthcare coaches?
Health coaches, yeah.
Yeah. So 1, the background of those people. And then 2, sounds like, correct me if I'm wrong, that's something that like Dr. Cole, who's an orthopedist, could supplement his practice with. He could just plug that into his existing OrthoSouth practice. And what are their backgrounds generally?
You talking about me being a health coach, or
no? I'm talking about
using a health coach.
No, I'm saying could your practice use ViTel Health's platform with your existing patients as an extra source of revenue, and also helping your patients? Say some of these people, you're going to say, well, you've got to lose 20 pounds before I'll replace your knee. Seems like a no-brainer that ViTel Health platform could get plugged into an orthopedic practice. And she said there's a revenue sharing model. So I'm just trying to clarify what their backgrounds are and what they could bring to any practice.
Yeah, and that's exactly.
Isn't it true that it's basically like a siloed service that, much like some groups, we have an MRI scanner. That's a revenue piece. It's a service. I guess practices could plug in and not have to hire the employees to manage it.
Exactly. Yeah. So it's a self-contained, or as you would say, like siloed service. Like there's no upkeep for you. Like I said, we hire all of these coaches. Our coaches have a variety of different backgrounds. Most of them have worked in coaching for a long period of time and have a certifying health coaching credential. So just like a nurse or a medical assistant goes to a particular training in order to get a certified credential. So we had looked around and found a credentialing body for healthcare coaches. And so we like to make sure that they all have that similar background. Some of them are actually certified through the American Board of Lifestyle Medicine. About half of them are nurses. So they are either retired or just didn't want to work in person anymore. So we often hire nurses. We have nutritionists on our team, like an actual clinical nutritionist used to work in a hospital. We had potentially a physical therapist that we've interviewed recently wanting to join the team. So the way we work is very much, I think, what do we call it? Collective intelligence in a way, right? Like, so a patient may be working with one specific coach with one specific background, but we call it collective genius. And so the collective genius of all the individuals meeting together, and we put all of our resources together, and we utilize Slack just for communication between each other. So at any point, if you're not feeling comfortable, you can talk to another coach on the team. You can talk to me. You can ask any questions that you have regarding patients. So we always keep the lines of communication open between all members of the team. And we really not just support, but like really want that for our coaches, right? Like we encourage them to ask questions, to, tell a patient when they don't really know what is the best resource for them, right? Like the best way to create relationship with a patient is actually just being honest and being vulnerable about something and say like, oh, wow, you're really dealing with this grief right now, which is why you gained 30 pounds. Like we cannot help you lose 30 pounds unless we deal with this grief you have over losing your husband. So that's not my area of expertise necessarily, but let me see what resources we have available to us so that we can really holistically manage your health. So we really try to take advantage of having a lot of people on our team with varying backgrounds so that we can constantly have another resource for our coaches to rely on. And then to your point, like, yes, it definitely is a no-brainer for physicians, especially orthopedic surgeons, who do often have to turn a patient away because they, don't meet the weight criteria, or like I said, going from an ASC to an inpatient surgery because you're thinking there could be a complication due to the patient's hypertension or due to the patient's diabetes. You're like, oh, they're just safer in the hospital. Like I just want them in the hospital so I know someone's checking on them after I've operated on them. Whereas the patient is hoping to get a same-day surgery and to go home where they're not going to pick up a nosocomial infection, where they're not going to be uncomfortable in a room wearing a hospital gown, like they're more likely to get up and move around post-operatively in their own home where they're comfortable, where they're wearing their own comfy sweatpants, and they're not afraid everyone's going to see their butt when they go walking down the hallway, So how do we help surgeons help their patients and also help their practice?
What about locale of your coaches? I can see how perhaps, patients that might work nights or have, they might want to take a call at 5 a.m. or at 8 p.m. Maybe if you have coaches that are a few time zones away, maybe that helps. Or is it more, is there more of a focus that they be somewhat regional? Does it matter?
It's a good thought. I like that idea as far as time zones with the patients. We haven't had that come up yet where our patients are asking for something that's like really early in the morning, although our coaches are kind of spread all over the place. So we might have somebody on Eastern time zone helping somebody in Mountain time. So the time zones are really important for that. But we do focus on having at least 1 to 2, depending on the size of the practice, local coaches. Like hopefully within less than an hour of the patients. Our equipment's super simple to use. Like, we specifically went with a vendor that had a cellular hub for the devices. So there's no Bluetooth, there's nothing for the patients to set up on their phones. They just plug the hub in their home. It turns red when a reading needs to be taken. It turns green if the readings have already been taken. It's just that easy. And they just simply use the device the way they would use anything else. Step on the scale, take their blood pressure, take their blood sugar, and all of that data is automatically transmitted back to our platform. So we wanted to be really smart about that, knowing that we had elderly patients. But we have had one patient so far who said they really needed help setting up the equipment. So it was important that we had a local coach who could drive to the patient's home, reassure the patient that it really is this simple to use, because the whole point of making money from RPM CCM is the patients do have to be consistent and they need to keep using the program. So, relationship helps with that. Ease of use definitely helps with that as well. And then when it comes to, social determinants of health, I cannot, in good conscience have a health coach in, Los Angeles, California, trying to help someone in downtown Detroit. Right? Like, that person has, unless they maybe grew up in Detroit, does not have a frame of reference for what that other person is going through. So from that standpoint, we want coaches to understand the locality where the patients are located, what kind of access they have as far as, like, where are the grocery stores? What are the grocery stores? Are there hazards in that environment when it would come to exercising? Like, maybe you can't just go for a walk outside, your neighborhood's unsafe. So it's really important for us to have coaches who understand what's going on in the patient's environment. And that was really important. I had heard a TED Talk many years ago about how a company was training midwives and basically like prenatal and postnatal support people in Africa, like just from the villages. And so it was very important for that person to be in the village and of the village and from the village to really understand what was happening for those mothers, and to provide the right level of support. And the mothers were a lot more, for lack of a better word, compliant with what was being told to them from a medical standpoint when they had someone to support them in that area. And I know that modality has transferred a bit, like, to underserved areas here, even in the United States, and impoverished areas where we can actually train what are called community health workers, who can go to people's homes, who understand what life is like with them and can provide the type of support they need. So we kind of have merged a medical model with a community health worker model, to provide really targeted support to our patients and to create the kind of relationships that keep patients coming back and keep them engaged.
When you talk about compliance or engagement, what are the measures? How can you measure the success and progress that you're making?
Yeah, I think, number one, we want patient subjective reports, right? Like, how do the patients feel? We look at, for patients focusing on weight loss, are they losing weight? Are their numbers better controlled than they were when they first started in the program? Are they consistently staying out of red alert zones for, like, their blood pressure or their diabetes? The other thing that we're looking at with some of our value-based care clients, or even like different Medicare plans, they take records of how many times the patient's been in the ER in the last 6 months, how many times the patient's been in the hospital in the last 6 months, what services are those patients using, and how much is it costing. So we look at those capitation numbers, and we're going to do more of like a prospective with those. That's a newer client for us. They've only been with us a few months. But as we get those patients utilizing the program, we can do that kind of longitudinal research, because they can see every 6 months at least how much healthcare the person is utilizing, and is that less than they used the month before. For us, like for the health coaches, the real measures that our coaches focus on are the quantity of visits that they can have with the patients. That's for CPT code compliance and monitoring. So our system is very elegant in the way that the coaches attest to the time that they spent with patients. So we don't just track it using a timer. We actually have the coaches attest to it. That's a really important aspect of Medicare compliance. And they write notes that correlate to the time spent with each individual patient. And at the end of the month, we're able to calculate like how many readings did the patient take, and then how many minutes were spent doing each of the activities that correlate either to the remote monitoring or the chronic care management, so that we can make sure we're billing all the right CPT codes, and our platform actually generates all those CPT codes for us based on the minutes that were attested to by the coaches. So it's a really elegant system. It keeps us in compliance without a lot of extra headache.
Is there an ideal number of patients or even a maximum number of patients that a coach handles?
Yeah, for our coaches, it's 150 patients on their panel. Reason for that is they're about 150 working hours in a month, like little more than that. So they have some time for administrative tasks. And they need to be able to realistically document that they spent that amount of time with patients so that we can maximize the CPT billing. So I would never get our doctors, like I said, into a legal or compliance situation where I billed for time that wasn't spent. Whereas many companies just say like, oh, well, we bill the max every month. Like, we're going to just send these out and we're going to bill these codes and we're going to hope nobody looks.
How many patients do you have in the ecosystem, and how many physicians and practices are in the ViTel ecosystem or platform?
Yeah. So within our remote patient monitoring platform, we have probably like 12 to 15 doctors. If I'd have to like go and count them, because some of the practices are bigger, and so they have some support staff, or not support staff. They're what do you call those? Ancillary service providers.
Mm-hmm.
So they have some of those, and then they fluctuate as far as like how many doctors they have at any given time. And then we have some really simple like one physician practices. And then as far as patients, we have about 500 patients in the program right now. We haven't been doing the RPM CCN, like I said, that long, about 18 months. Like any good technology company or SaaS company or service company, we took a crawl, walk, run approach, which is, we had one physician for like a year who was a concierge practice, and he would onboard at the perfect rate, which was very slowly. And then we had just one coach assigned to him, and that's been his coach this whole time. And they've built that relationship, and we've worked out, as many of the possible, kinks and errors and compliance issues that could possibly come up in running an RPM CCM company. And then we started opening it up. So he would refer his, physician colleagues to us in his area. So we would take them on as clients as well. We've had other larger groups reach out to work with us, just through finding us, maybe through a podcast like this. And then we also have channel partners who do other things within the medical ecosystem. So like shared medical appointments is something that's getting a lot of attention right now, for different specialty practices. And so when they bring shared medical appointments to a specialty practice, oftentimes they also ask about remote monitoring and chronic care management as part of that package. So we partner with them to provide that on our side. So a lot of different ways that we encounter physicians. We're definitely at the beginning of our growth phase, but we're sensing a significant hockey stick.
Do you require your health coaches to be full-time, or is it possible for someone to work 2 days a week, 3 days a week, something like that?
We do balance that. So we have a couple part-time health coaches who are brought on just because they're really excellent at what they do, and they do some administrative work as well in their off hours. But many of them are full-time. So it's a little bit easier to manage them when they're not them, but their patient responsibilities when they're full-time, because otherwise if they're off one day, then someone else has to be following up on the readings for those patients. We can't just let the patients go without someone monitoring them for a couple of days. So then you have the balance of responsibilities for those patients would fall onto other people. Since we're not big enough yet where like I can say, oh, I definitely have 10 people working Mondays and 10 Tuesdays and 10 Wednesdays, so I can kind of balance that. So like, oh, these people are only going to work Monday, Wednesday, Friday, and these other people are going to pick up the slack for them Tuesday, Thursdays. It's a little different from that standpoint when we're small. I think as we become a larger, more established organization, it will be more commonplace for us to have part-time staff and part-time workers sharing the responsibilities with each other. But we've done a good job so far balancing that for the 2 part-time individuals that we have.
Other than podcasts, how are you marketing ViTel?
So we actually have an internal marketing team who do basically like cold calls to physician offices, telling them about the services that we have. We have our website, we have my LinkedIn, where I talk a lot about remote patient monitoring and how to avoid some of the pitfalls and the legal risks that these other companies just won't even tell you exist. So I like to make sure that physicians are very well educated in this space. Just like I said, like most things, when someone's trying to sell you something, they're going to make it sound like it's super simple and there's zero risk associated with it. You're just going to take home a check at the end of the day. And that happens to physicians a lot, right? Like they want to use your license for this med spa and they want to use your license for this, like MAT program, medication assisted therapy program. It's like, oh, it's okay. We just need to use your license and your NPI. And it's like, well, at the end of the day, like, that credential identifies you as the 100% responsible party for anything that could possibly go wrong. So there's no zero risk proposition when it comes to letting other people use your credential.
Right.
So I use a lot of educational as marketing. And then again, like I said, through channel partners who market for us as well.
Most people that go to medical school have lots of ideals and dreams about their future and their practice. Jail time isn't one of them.
No. And sadly, a lot of them, even if they don't end up serving jail time, which I have talked to doctors who have, not necessarily for RPM CCM, but for other things. But I was talking to a healthcare attorney the other day, actually down in Texas, where you guys are located, Dr. Amanda Hill, and she's amazing. So any physicians listening in Texas have health legal questions, like look her up. But she was telling me that, unfortunately, being a lawyer, she gets called when things go really, really bad. And the physicians just want so badly to help their patients, and they're oftentimes taken advantage of. So she told me the story of a physician whose mother had diabetes. And so when she heard about remote patient monitoring for diabetic patients, a company it was very easy for them to sell this to her. Like, oh yeah, we partner your patients with a nurse practitioner and they're all going to get a glucometer and we're going to monitor them. And then we'll, bill Medicare for it and we'll give you a check at the end of the month. Everything will be good. Turns out they never sent out a single glucometer. There was no nurse practitioner. All they did was send bills.
Yeah, that's called fraud.
Yeah. And the
know better than that.
Figured that out right away.
Yeah.
But by then it was too late. It had already been done. And she had to self-identify herself to Medicare as being complicit in fraud. And that does not work out well for you when it comes to your license and your credentials and sanctions that can be pulled against you. So it's really, really important for doctors to know who they're working with, to be able to trust who they're working with, and to realize that things can go wrong. And unfortunately, there are people out there who are profiteering off of our willingness to just want to help.
Brittany, we want to know more about the founders. I know you're a co-founder here. So tell us about you. Tell us about your other co-founders.
Yeah, for sure. So, about me, I'm a physician. My co-founder, his name is Doug Sumaraga. He has, an incredibly, I just think it's an incredible background, honestly. Every time he tells about his background during one of our pitches, I'm even more impressed. He came out of school with a medical technology background and started working in Fremont in the technology space. So kind of stayed away from medicine in the first part of it, was one of the leaders at SAP, one of the leaders in supply chain for Apple, and at the Mac factory. and actually worked with Northrop Grumman and was in charge of training and deploying thousands of baggage handlers after the 9/11 incident. So when it comes to organizational process, when it comes to technology, and he's founded companies in the technology space. I actually had worked with him at my prior telehealth company where we worked in occupational health, which is how we met. And just knowing that he had the capabilities to organize, to develop processes, and to evaluate technology, which were not really my strengths, right? Like I'm a people person. I love relationships. I love connections. But I tell my team all the time, like I need process people. I need to be surrounded by operations people who can scale things, because relationships are amazing. And they are scalable, but only if you have the know-how and the process around it.
So I've watched you on LinkedIn. That's how I first learned about ViTel. So we can say your team's doing a good job there. I think when we spoke before, you mentioned working with Lee Houston, perhaps on the credentialing piece. I saw that Harvey Castro is on your board. So those are some familiar names for people that look at LinkedIn from time to time. Can you maybe talk about those two pieces and what they bring?
Yeah, so Harvey started working with us a little over a year ago, right after he had released his book, ChatGPT in Healthcare. So I talked about like relationships and scale, looking at the balance between one-on-one visits and care pods. You have to have a different kind of balance nowadays so that things can become more scalable. So we've taken a hard look at how AI can help physicians, and where we incorporate that into our workflows. So from utilizing it to condense information from the subjective and objective part of the note into an assessment so that the doctors don't have to rewrite that part, to interviewing patients for prior to coming to their appointments. So looking at how we can use AI to take more concise and not concise, but better histories for the physicians who are going to see their patients. So Harvey's been really instrumental in helping us evaluate new AI companies, again, looking at compliance issues, legal issues, things that he's really immersed himself in that I really haven't had the time or bandwidth to do. So that's why you want to surround yourself with people who are really smart in areas where you're, not as strong. Leah and I have worked together as far as utilizing her platform. We talked a bit about in the beginning about credentialing and contracting. I think absolutely physicians need to be in charge of that credential. I think we talked about that a bunch here. Like, this is your credential. You are responsible for it. Like, make sure legally no one else is using it. And in order to do that, we need a system that prioritizes physician ownership of these credentials. So working with Leah as she develops her product for go-to-market, like working very closely with her on what our needs are, as we plan out and develop a medical group, how do we streamline the credentialing and contracting process using her technology? Because it's really amazing what they can do with the blockchain, not just from identity verification, but also from cutting down the amount of time that it takes. As normally the credentialing contracting process can take anywhere from 30 to 90 days. But with these instantaneously verifiable credentials, you can cut that down to mere minutes.
Jeff and I are both pretty analytical guys. We're wondering, Jeff had sent me this question earlier. Do you have objective data showing, ViTel providing decreased hospital admissions or fewer readmissions and things like that?
Yeah, I think we had talked on that a little bit. We have a practice who does have the data for their patients as far as hospital admissions. They keep really good track of that. And they just started a couple months ago. So it'll probably be another 4 to 6 months before we can compare their baseline data to our interventional data. And we haven't onboarded that many other patients. So it would probably be more like case study format at this point. But over the long term, I think over the next 1 to 2 years, we will be able to come up with a lot more data on that. I'm like you guys, I have a research background. Like, I want to make sure that when we're making those types of comparisons, like, that we can really say, like, this was the intervention, this was the effect that we noticed, and I want that to be a measurable effect. So we want to make sure that we have enough data
Right.
collated before we start making claims that we did something.
And then I wanted to get into the financials. I don't think I got the pitch deck. If I did, I didn't have a chance to review it. What you're in the middle of a fundraise. Tell us about that, what you think the market size looks like, et cetera.
Yeah. So market size is extremely large when you're looking at just Medicare patients alone, right? So we have, I'd have to bring up the exact numbers. You guys could probably bring up the slides. I know
Well,
Jeff.
it's like everybody, right? It's
Yeah, but
potential.
basically, like, if you look at the Medicare population, probably about 80% of Medicare patients have at least 2 chronic conditions. And that's just based on the data from the Medicare and CMS. So if you look at that as kind of like your total market, we're looking to achieve, if we could even get, 5% of that, we'd be doing really well, like into the billions of dollars. So it's a huge opportunity for this market. With the contracts that we have right now, even being on the smaller side, you're looking at revenue of 50 to 100,000 per month for a small company, which would be kind of equivalent for a small practice. So we actually have a revenue calculator that we can utilize with our clients when they're looking at how much revenue will this generate for their practice. We can show them like how much additional revenue they would expect based on the number of physicians, the number of providers within their practice, the number of patients that they have, and just some, very baseline characteristics. If you are a geriatrics practice, obviously the number is going to go a lot higher. Whereas if you're more of a general medical practice and only, 30% of your population is Medicare, then the numbers are going to be smaller. So we do have a pretty elegant revenue calculator. I believe it was on our website. We may have moved it though. But you can always message me and I'll be able to put you in touch with the people who can show you that.
And then
to
tell
look
us
at your offerings, and this is backtracking just a little bit, but if somebody, a practice or an individual came in, do you have almost a menu where they click, yes, I need legal, yes, I need credentialing, yes, I need, and is that something that you've brought into kind of a membership model, or is there per service pricing, or is it more you refer them to that entity and that's a separate cost?
Yeah, so that's part of the evolution of ViTel Health. ViTel Health as a technology company obviously exists, very successful. If you do, want to see our pitch deck, if you're interested in investing, that would be ViTel Health as the technology company as it exists right now. We've spun off a ViTel Health physician cooperative, which is an independent medical group. And the independent medical group will function exactly as I've stated, as a cooperative. So it's a professional corporation so that we can bill Medicare or other insurance companies, incorporated here in the state of California just this year. And then from the cooperative bylaws standpoint, it's based on an agricultural cooperative model where we do group purchasing for things like malpractice, like I said, looking at shared medical space, shared services, shared purchasing, shared contracting, because most of these companies will say like, oh, you're a single physician practice or 2 or 3 physician practice. Like, we're going to charge you $250 per provider per contract for contracting. Okay. If I say I have 100 providers at my medical practice, okay, suddenly the rate goes way down, and so if 100 of us are splitting the cost, it becomes a lot more reasonable. So the goal is to, have people participate in the membership, take advantage of cost of, what do we call that? Economy of scale.
Yeah, for sure. Yep. What about the fund? We didn't talk about the fundraise that you're currently in.
Yeah, so the fundraise that we're currently raising right now, like I said, ViTel Health as a technology company, ViTel Health proper, we're raising to expand and to grow the RPM CCM component. This will be essentially what we call a seed plus round. We raised a seed early on on similar terms. So we'll be raising a seed plus on our way to a Series A, probably by the end of 2024 or early 2025. At that point, we'd be looking more at like 50 million valuation. Right now, we're raising on a 15 million valuation for $1.5 million. We're doing that on the basis that given the growth just in our current contracts alone, like not bringing in a single additional physician's office, which would be crazy. I don't know how we'd go a whole year without bringing in a single new client, but say that happens. Just with the growth in our current clients alone, we are projected to have about a 5.5 million annual recurring revenue by the end of this year. So, and those are very conservative as far as projections go. So we thought we could raise 1.5 to stabilize and or accelerate that growth and get to that 5 million mark. And once we've hit the 5 million ARR, then we would head into the Series A.
Mm-hmm. And you're in California. Are all of your practices in California?
They are not. Actually, our practices are in California, in Arizona, and on the East Coast, I think Pennsylvania, Delaware.
And they belong to the cooperative if they're not in California?
No, they do not. Not yet.
How does that work? Will you have to get some sort of regulatory sign off in the other states, or?
Because these are just for the RPM CCM practices that are using that. So like we talked about, that's kind of a siloed offering. So the doctors can be, our doctors, none of them who are using the RPM CCM are even using the ViTel Health EHR. They're using the entirely separate platform that's only for RPM and CCM. That's built as an add-on module to the EHR proper. So you can utilize the RPM CCM be any stage of a physician corporation. So most of them are using anything from like in-house built EHRs to like ECW or eClinicalWorks, Elation, Office Ally, like all different kinds of EHRs. So they don't necessarily have to be part of the cooperative to utilize our services. The same goes the other way too. If a physician is a member of the cooperative, there is no there's nothing tying them to having to buy services from ViTel Health. Like our goal is to include all physicians, regardless of practice, whether they practice for a hospital, whether they practice for a group, so that we can come together and we can start working together towards the things that are in our best interest. So to take down the corporate practice of medicine, to improve the lives of physicians overall. So the cooperative is a lot more powerful the more people who are involved.
Right. I guess my question was if a practice is part of the cooperative and wanting to take advantage of the group purchasing, do they have to be in California?
No, they don't. No, we would be setting up separate business entities, just as like from an HR standpoint. You just need a separate business license to sell in those states.
Gotcha.
So Jeff, you've got me really thinking about something here. Maybe this is a whole nother podcast, but this is the right person to have the conversation with. Would there be any law or regulation preventing a nationwide co-op?
No, there isn't.
Because I think that's a barrier to our success right now, is that physicians have been fragmented and we can't achieve the economy of scale that a hospital system or a big insurance company can. And so we're captive to being employed.
We are.
And the patients suffer and we suffer. And, the data is all out there on how miserable everybody is in healthcare, including the patients. The hospitals are broke. And so.
Yeah, no, there's absolutely no legal reason why we can't practice all together.
Yeah.
And run our business services through it. You see all the time, medical groups are typically housed, like I said, my experience is in telehealth. So I had doctors practicing all over the country, living all over the country, and we were all utilizing the same medical group based in California for those services. So as a medical group, our purchasing, credentialing, contracting, all of that's done through the group. And then each individual physician purchases their share of the services that the group has already purchased.
We just posted this thing that came out at AMA. It said there was a survey done. 40% of physicians are contemplating leaving within the next 2 years.
Yeah.
And, this is already with the exodus that took place after COVID. And whether that survey was accurate, I can't tell you, but the trend is there and none of us can deny it. But the thing that most of the comments on social media discussed lack of autonomy as the reason. And so it looks like ViTel, is giving that back.
Our goal was always physicians who are independent but not alone, right? I think that we see health systems as almost like this safe place where like we can play well with others. And there wasn't anything, no existing structure for that in the greater world, right? Like not anymore. There used to be, but then it kind of all got absorbed by health systems and private equity. So the physicians were very scared to be alone in the world. Like that wasn't our model that we were comfortable with. And so we wanted to really make that something that was more attainable for every physician, like independence, autonomy, all of those things. As far as the survey, like I don't not believe that 40% of physicians will say that they want to leave. I think there was another study that was published actually like several years ago that looked at kind of a similar thing where like they interviewed all the physicians and they were like 60% of them said they were going to leave. And then they looked at it 5 years later and like less than 10% of those doctors actually left.
Yeah, but the people that can leave are the best and the brightest that can do something else to support themselves financially. So It dilutes the talent that's available for patients even further. Or what you've got is people like, Jeff and I's age that we're just kind of stuck with the fire we've got going. And we got to just keep chugging along. But then you see stuff like 90% of physicians are depressed. And, do you practice clinically, and when did you graduate from med school, if you don't mind me asking?
I graduated in 2009 from the University of Wisconsin. I went and did a surgical residency here in Sacramento at UC Davis. I did 3 clinical years. And then during my research year, I was diagnosed with bilateral retinal detachment.
Oh, goodness.
And I underwent emergency surgery for that. It was just found on like a random visit where a medical student was like, "Can I dilate your eyes?" And I was like,
"Sure."
Get lost, and then I let them do it. And it like, they all just like freaked out. They were like, "What is wrong with your retinas?" And so,
holy cow,
miraculously found that, but then also really showed me all of the ways that like the system had been just destroying me as a human being.
Yeah.
Like really put a microscope on that during my recovery period. I said, like, I can't continue to live in the system. So I worked at urgent care for a while, got involved in telehealth in 2016, really when telehealth was first starting out, and still saw physicians continually abused, taken advantage of, not paid in a timely manner. And when they were paid, it was like so little for the work that they were doing on behalf of these companies. This is not just, it's not untenable. It's like just disgusting to me.
Yeah,
so
it's just wrong.
It was born out of that. Like, we can do this. Like, we don't need to work for the Teledocs and the Sesames of the world. Like, we can do this ourselves. Like, the technology exists. So I thought that was the best way to use everything that I learned, especially like from 2016 on, about digital health, and just really organize and empower my physician colleagues to do better for themselves and for their patients.
Yeah, I think
you use the word pawns because I see that, where we are. Yet, I think I wrote it in that thing the other day that physicians they've got intellect. They're smart. They've got drive beyond most any other professional people that I know, and they've got opportunity to do other things. And so, you just hope we keep physicians in the job, but find ways to promote that, like what you're doing.
Yeah.
I looked up this morning because I wrote another follow-up thing to that deal the other day. I mean, United Health Group last quarter.
Yeah.
It's like 70, I forget if it's 75 or $95 billion.
Yeah.
That's patients' premiums.
And yet they raised premiums and cut payments to physicians.
Yeah.
And okay, how much more money do you guys
how much
need?
is enough? Yeah. It's
you should look at like what, if you talk to like Sandeep from Mishi Health at all?
I haven't. I know his name, but I have not talked to him.
Yeah, Sandeep's working with me. We have another meeting on Monday. We always kind of tag each other in similar posts because like I said in one of my posts, like the turning point, like where something becomes socially acceptable is like very small. It's like 7 or 8%. But like the actual like tipping point where it would be considered a social norm for everyone to be an independent physician again is actually only 30%. So the optics is that 80 to 90% of people are doing it when only 30% of people are doing it. So we always tag each other like goal is 30 by 2025. And like, what would it take to get 30% of doctors interested and starting to practice independently by 2025? Because if we can get that amount of physicians doing it, then it's going to appear to all of the medical students that that is the social norm and practice again.
Yeah.
And
plus just the growing prevalence of, direct pay models and cash, because I think people are getting smart to think, maybe I'm just going to have a catastrophic insurance.
Yeah.
And bring down this crazy deductible, 4 or 5.
Well, it's like what Dr. Brown said about car insurance. Okay, car insurance covers catastrophic events, car wrecks. Can you imagine if car insurance were meant to pay for your gas? Like, just picture this. I'm going to go on a road trip and I'm going to leave California. I'm going to go visit my mom in Tennessee. So I start driving and I need to get gas relatively frequently, like every couple of days. You got
to find a gas station in your
car
network.
Insurance decides that I've used too much gas.
Yeah.
Like my stipend of gas is supposed to be once every 2 weeks. So how dare you use that much gas, right? So they're going to cut me off. And then I'm going to be stranded like in Oklahoma somewhere, like no longer in California, not in Tennessee. And like, well, at this point, you could use your insurance and pay your deductible to get towed to Tennessee or back to California. You're like, what? Yeah. No, that is not how that is supposed to work. Like, I'm supposed to be able to use gas.
Would you like to be introduced to somebody that's doing a direct patient care model company?
Yeah, I'd love to. Yeah, I know Mishi is like that too. Like, well, they're just kind of collating everyone together, but patients can actually go there and find direct pay physicians and find the services that they need and see how much it costs. So it's all focused on cash pay and price transparency.
Well, I met a guy a couple of weeks ago. We're going to end up putting him on the podcast. That's what he's doing. He's growing rapidly. He goes straight to the employers, and they, in a nutshell, they cut out Cigna, Blue Cross Blue Shield. They go to the employers. They go directly to the physicians. They go directly to the radiologists and say, hey, how much are you getting with Blue Cross Blue Shield for an MRI? They actually can pay the radiologist more, cut Blue Cross Blue Shield completely out. The patient goes and gets their MRI the same day, pays less, and everybody's happy, including the employer. The only thing that I didn't understand is, like, we talked a little bit about the catastrophic stuff and how that's handled. He said you can rent the PPO, and I didn't really understand what he meant by that, but we're going to learn more. Because
that's where I really see like the cooperative growing. And like, because really the main thing, I think that there are main things that the physicians ask me when they want to start an independent practice. Like, technology is, whatever it is, a dime a dozen, but they want to know, where do they get patients and how do they pay for like malpractice and benefits and stuff like that. And so those are some of the issues that we've looked at solving. And I think the best way to solve the patient issue is to partner with people who are already selling direct pay insurance, for lack of a better word. Obviously, doctors aren't the only people who can see that the current medical system sucks. And like, you can make fun predictions all day, but like mine are like, Amazon will pull out of healthcare. Like, they have no business being there. They're going to realize that in the next like year or two, and they're just going to like dump all of their healthcare interests. And number two is insurance companies think they're too big to fail. They're not. Like, there will be people who eat away at their current hold, for lack of a word, on employers. And they'll do that very successfully. And next thing you know, UHC will be filing for bankruptcy.
That's a sound bite.
I'd love that.
I believe it. I believe that that the BUCAs will eventually file for bankruptcy, and we're probably going to see that in the next 10 years.
It's a David and Goliath battle, though.
And paying for your sins, and just, what they've done is just not good for the U.S., for patients, for the whole healthcare system.
And you think it only took, I mean, it probably took less than 10 years for them to achieve that size. Like once, managed care agreements went into place in like, what is that, late 80s, early 90s. And then suddenly everyone had that. And like, I remember like very vividly, because my dad was a UAW worker and we had HMO or whatever. It was very good insurance. No copays, no deductibles. He didn't pay the premium, the GM paid all of it. And the first time my mom ever had to pay a copay, it was like $5. She freaked out. She was like, what the heck? This is health insurance. Like, I have health insurance. You can't charge me $5.
Yeah.
And that was $5. Like nowadays people are paying like $100 or more out of pocket. And I was even looking at like my boyfriend's plan, like he pays $600 a month for Kaiser. And they still charged him like $250 to use the ER for a laceration and charge $20 per prescription. And when I look at like GoodRx, for example, for the exact same generic prescription, $12.
Yeah, that's the craziest thing ever. I just use GoodRx and it's cheaper than my insurance that I'm paying for.
Yeah.
Explain that.
I don't know. That's where the $70 billion comes from, right?
Yeah,
like
that's right.
Like then they own the PBMs and they own Optum and they own all of this. So it's like everywhere they can, shave an extra dollar off of you, times 10 million subscribers, right? Like they're rolling in cash and they think that we don't notice because Americans are bad at math.
Yeah, maybe some are.
Yeah, exactly. And soon even the ones who are bad at math are going to know that they're getting ripped off.
Man, I'm glad you're doing this. And I wish you all the success in the world. We're definitely going to
partners. Like this is a huge problem, honestly, huge. And one physician company, like we're not going to solve it. But if we can really solve our piece of it really well and partner with the other people solving their piece really, really well, like that's when you really create, like, it's not just David versus Goliath. Now it's a whole army.
Yeah.
Well, and I think that even just the voice, I think collaborating through our voice is important. I see your stuff. I'm liking it. I'm,
for sure.
Do the same. And I just think all of a sudden we start to meet each other, some of the other folks that are speaking up in these threads. And
I always comb through other people's threads when it looks like they're talking about the same thing as me. And then I like connect with all the people commenting on their stuff who I'm not connected to yet.
Mm-hmm.
Like, if you like this, you'll like what I have to say, kind of
thing. That's right. Well, we've got a lot of synergy with groups we've already talked with and our own personal passions, Jeff and I do. So we're not done with this conversation. We're just getting started. So Brittany, I'd really like to thank you for joining us today. If I've understood correctly, it's been a fascinating conversation. ViTel offers a turnkey suite of products and services to promote physician independent practices while also increasing revenue for those practices, while at the same time promoting wellness and health for the patients.
That sounds like a perfect summary of what we do. Okay, I'm going to have to save that, for when they say, like, can you summarize what you do in 20 words or less? I tend to be a pretty verbose person.
This was great.
Perfect. Thank you.
Yeah, thank you for joining us for the Merge Medical Podcast. I'm your host, Dr. Jeff Brown, with my co-host, Dr. Jeff Cole and Dr. Brittany Busse.